And so ketamine works when a lot of other things have failed.
Wow.
Yeah, pretty cool.
That's actually very promising.
Yeah.
Because we don't have any good therapies for
No, we
that.
don't.
The common theme between the fibro, the IBS, and some of the other disorders is that they basically have neuroplastic pain.
Exactly.
Which is by far the most resistant to therapy, including opioid therapy.
Yeah. And what we found was 75% of our patients were having a 50 to 100% response. And we're like, wow, this is pretty impressive. All of the studies are positive. Ketamine seems to work in the brain, not on 1 or 2 or 3, but about 5 different systems. One of the advantages of ketamine is that it doesn't suppress your breathing.
One concern a lot of people have is actually about the addiction potential. What are the actual numbers?
Yeah, I mean, there's a lot of bad science out there.
Yeah. If you had to pick just one type of patient or condition that would be the most appropriate or promising when it comes to ketamine.
Yeah, so generally it's someone who's had...
We're going to be talking about the uses of ketamine in both chronic pain and in headache medicine. Peter, or Dr. McAllister, for those who don't know him, is an expert in migraine, headache medicine. He has a special interest in ketamine as well. So he's going to be teaching us about the science behind ketamine and also about the latest evidence in terms of its use in both headache medicine and chronic pain.
Thank you, Ali. Thank you for inviting me in for this. I've had an interest in ketamine for about 9 years. When at our center, I wanted something that I could give my patients who have pretty much failed everything else. And I borrowed a protocol from Johns Hopkins University. They were one of the earlier pioneers into using ketamine for pain. Because as you know, ketamine's been around since the 60s. And it's used as an anesthetic. It's in ORs and emergency rooms and ICUs, used all the time. And it is both an analgesic or pain reducer, and at higher doses, it's also an anesthetic. So I looked into what was going on about 9 or 10 years ago with this new idea that if you give a fairly high dose for either every other or continuous days for a bit, you could affect change in the brain. And we didn't know exactly what we were doing. We knew we wanted to be safe, and we were convinced that we had the safety, and then we pioneered it with our patients. And we initially used it for the ones who had just really failed everything. So our severe chronic migraine patients, our chronic cluster patients, these rare headache syndromes that are hard to find, something called SUNCT and SUNA, and severe trigeminal neuralgia. And what we found was that when patients get their 60 to 90 minutes of kind of floating away, and they come back, and the next day we go to a higher dose and higher, by day 4, the highest dose, we then try to quantify the success. So we do a lot of research at our institution. We also have medical students who come through. So we had the medical students follow up with these early patients and call them day 1 after week 1, month 3. Yes. And what we found was 75% of our patients were having a 50 to 100% response. And we're like, wow, this is pretty impressive. So with time, we wound up broadening it. In the pain realm, we can talk about other indications later. We're using it a lot for, spine pain, severe back and neck pains, nerve pains, burn pains, all sorts of things that, you've tried pills, you've tried maybe injections. Someone who's talented like you can stick a needle in under X-ray and try to fix them that way. And there's always a group that succeeds with each of those, right, but there's always a group that doesn't. And so ketamine works when a lot of other things have failed. And that's one of the things I like about it.
So should we think about it as a last resort?
So increasingly, it's becoming less of the last resort.
Okay.
We started out that way. What we found was a very good safety profile. Now, mind you, we have the patients hooked up to blood pressure and heart monitor and pulse and all that, but I jokingly tell our patients, we could just as soon have the machine off. One of the advantages of ketamine is that it doesn't suppress your breathing. It doesn't really change your pulse much or your blood pressure. Occasionally we see a little increase in blood pressure, but not much. So we've not had any safety issues. So now we have the discussion earlier on. because some people just don't like meds, and some people have side effects, and some people can't remember to take their medicines. So we don't wait till the very end sometimes. It's never the first line. But there are some patients we say, or we have this other option where we can do a few days in a row, a very high dose ketamine, try to put you into a remission and see how you do. So we're using it a little sooner than we used to.
In your mind, who would be the most ideal patient, like a poster child patient for ketamine?
Yeah, so generally it's someone who's had, chronic pain for a while, at least of moderate severity, if not more. Someone who I think it's functionally impacting them, right? Somebody who has tried a few things. Remember, I just said it's not our last one, but you've been through a few meds or some interventional procedures, and or you're sensitive to every med and you just can't tolerate them. You're looking for something else. There are some people who are always looking for something outside the normal box. They've been to doctors and, they've kind of just not gotten the care. We also know, and we can talk about this later, if there's other things rolling around in your head in addition to pain, you can have a 2-for-1. It can help other things too. So that's another group that I really think would benefit from a discussion of ketamine.
Yeah, and I think that's a good point for a lot of the patients who have more than one chronic pain disorder, right? So let's say they have chronic migraine and they have on top of it fibromyalgia and they have CRPS, right? So you would assume that they have a lot of central sensitization happening at the brain level. And so ketamine potentially would be a good option to hit all three at the same time.
Yeah. I wrote a paper some years ago and I borrowed or maybe ripped off a Quentin Tarantino movie title called The Hateful Eight.
I love it. It's
a great movie.
Especially in the snow.
But this patient said to me, is a woman in her 40s and she's seeing me for chronic migraine.
Yeah.
And I said, do you have any other pain? She said, I have 7 other pain disorders, but I've got 7 other doctors for each of those. And I said, what do you have? And she said, well, in addition to my headache, that's your thing, I have chronic neck pain, I have non-cardiac chest pain, irritable bowel syndrome, interstitial cystitis, painful intercourse, plantar fasciitis. And the tie together was she'd had trauma. And so when we discussed that, ketamine was the ideal medicine for her. And that plus therapy, some other things, we got her substantially better when many doctors had tried and failed.
Interesting. So. Now, one thing I remember from my fellowship when I was in New York is basically we used to get a lot of very severe cases of CRPS who are basically already on very high doses of opioids. And despite all the opioids, they were still in pain. And so they would come in and we would admit them for a whole weekend and just do ketamine.
Right.
And they would get excellent benefit. So tell us a little more about the use of ketamine in people who have either failed or basically people that the opioids are not working as well anymore.
Yeah, so, sometimes people can be on opioids and have a continued response. But as you know, because you're a pain specialist, sometimes your body gets hungrier and hungrier for the medicine. You get less and less a response until you're on massive doses with no response, right? We've seen that. That's where ketamine can come in. Ketamine seems to work in the brain, not on 1 or 2 or 3, but about 5 different systems. It has some direct opioid effect, including delta opioid receptors, which is pretty cool, right? It also has serotonergic and dopaminergic. But the biggest thing is this NMDA blocker. And when you block NMDA, you preferentially shift to the AMPA receptor. And this gets a little in the weeds, but what that does through something called mTOR, is it makes new proteins, new synaptic connections, new dendrites, and there are mouse studies in which you give ketamine and you can see compared to mouse before and mouse after ketamine, the ketamine mouse has many more synaptic connections and has sprouted new dendrites. And we talk to patients conceptually about this kind of workaround. If you've got chronic pain, let's say you've got your leg is complex regional pain syndrome, you've developed a pain loop in your brain and it's getting reinforced and everything else around it's withering. And the conceptual idea of ketamine is to have build-arounds by new dendrites forming, new synaptic connections to work around this loop. And that's why we think a drug that literally lasts in your blood system for 3 hours, how do we get the long-term effect? it's probably by this neuroplasticity,
Right.
these new dendrites, these new synapses. In our prospective database, of which we have our medical students following it,
How many patients do you have, by the way?
it's over 1,600.
That's a lot.
Yeah, it's a lot of
Wow.
patients.
Okay.
We have a group, it's a small group, perhaps a quarter, that the 4 or 6 days of ketamine infusion, and they're done. Their pain is either substantially better or gone, and they don't need it anymore. But the majority of folks, it will have a nice long effect. It might be 2, 3, 5, even 6 months. And eventually that pain may come back.
Right.
And we're not exactly sure why. But those people then benefit from what we call a booster, which can be a 1 day, a 2 day. So we have some patients who, rather than take opioids or a whole bunch of other pills, can get better and then come in 2 or 3, maybe 4 times a year for a day or 2 infusion.
Okay.
And in between, they're not taking meds. So it's pretty cool.
It is cool. I mean, one thing that's interesting about ketamine is that it's probably one of the very few medications that we have that actually work on the NMDA system,
Yes.
right? I mean, when it comes to migraine or even chronic pain in general,
Yeah.
I don't think we have any other medications that actually target the NMDA receptor, do we?
No, I mean, you know about memantine, which
Right.
is an oral agent.
More
and
for
often-
memory and dementias.
Correct.
Yeah.
Every now and then we use it for migraine, and it's thought to work mostly on NMDA. But in my opinion, if memantine is here, ketamine is here.
Right.
It's just a different level.
Yeah.
So we have nothing as far as we currently that does what ketamine does. And in addition to the high dose intravenous ketamine, just to kind of induce a remission, almost think of it like a cancer, this pain, right? We also have other options for them. So some patients, we can do a compounded ketamine nasal spray, and it's not nearly as high a blood level or brain level, we believe, as IV. But if they get a little bit of that feeling back at home, a week, once or twice a week, they can do a few sprays and they can knock things down. We're also looking at, and this is even newer, the concept of kind of micro dosing. It's a popular term lately, but using a very small dose of ketamine once a day to kind of keep things at bay.
Interesting.
And we have no prospective data on that yet.
Yeah.
We hopefully are going to be doing a project with a researcher from Seattle shortly, but maybe in a follow-up podcast, I'll have data for you.
That'd be cool. I mean, with the IV ketamine, I feel like I have a higher confidence in terms of the levels in the blood. When it comes to the nasal route, what would you say about the reliability of that?
Yeah, the bioavailability from the orally absorbed, a pill, a troche or something, is very low.
Right.
Sublingual is a bit higher, nasal spray is a bit higher, but you're right, it is a bit unpredictable. The interesting thing, though, I will tell you, having a lot of experience with ketamine in the IV, there are some fairly skinny little people who need massive doses. And there are some, 6'5" guys who fairly small doses and they're out. So I think even with the IV, you have to adjust, which is why we have a safe, reasonable starting dose. And then our nurses are all taught, our ketamine specialty nurses, how to give boluses based on either vital signs or the patient. I mean, the patient should be gently floating away. And if they're not, we know how to modify it. And there are people who we say, boy, that little person took a ton of ketamine.
What does it depend on? Is it the history of drug use in the past or anything?
Not sure. I think it's probably just how it's metabolized.
Okay. So genetics.
Yeah, I think it's mostly a genetic thing.
Which is interesting because ketamine, at this point at least, is dosed by weight. Right?
Yes.
So it's usually 0.1 milligram per
So
kilogram?
we started off at 0.25 milligrams per kilogram. We now know that 98% of people, that's not going to be enough even to start. So again, time has taught us.
Right.
We've learned a lot over the years.
Exactly.
Time has taught us to really start at about 0.4. And the literature suggests that if you can get them into the 1.5 to 2 milligram per kilogram by the last day, they have a better outcome. Yeah. The outcomes are interesting because we do a lot of clinical research, as you know, but because ketamine is an older drug, no big pharmaceutical company is going to invest $200 million in a trial. So all of the data is, 20 patients in this trial, 11 patients in this trial, 6 patients in this
It's
trial.
very small, yeah.
Very small. The thing I like to say though is if you look at them all, you've got lots of little circumstantial evidence that all points in the right direction. All of the studies are positive. It's been compared to placebo, just IV water. It's been compared to opiates. It's been compared to midazolam, which is another sedating medication, right? And it comes out on top. But again, they're small. And as a researcher, there's plenty to critique in those studies. They're not big and powered like if you had, 1,100 patients in.
That's the thing.
It's just not going to happen.
Is it limited because of regulations? I mean, I'm assuming it's a very highly controlled substance.
Well, it's in the schedule. It's a Schedule 3. So it's not,
I would have expected it to be Schedule 1 or 2.
No.
If marijuana is Schedule 1.
Yeah, it's kind of a mid-major.
That's interesting.
There's actually an epilepsy drug, that Fycompa, that's also a Schedule 3. I mean, so, because that, it's like anything that affects the brain. Fortunately, there's a big built-in safety with ketamine compared to other drugs, but there's no drug that is completely free from abuse potential, etc. And that's why it's scheduled, but it's not big because if you take too much morphine or oxy, you can kill yourself rather quickly. That's a higher schedule, right? So it is not 100% safe, but it's got along the scale, if you look at a plot of both addictive potential and potential lethality as you take too much, it's in the lower 20 percentile. Okay, so cocaine and heroin clearly, and methamphetamine, and all these are much, much higher. And the only ones that are lower would be things like psilocybin and et cetera, which are very, very low.
Right. One concern a lot of people have is actually about the addiction potential. What are the actual numbers in terms of the rates of some kind of physical dependence or addiction later on?
Yeah, much less than benzodiazepines, much less than opiates. It's kind of below those. So if you've been on those, you've been on something that has more abuse or addiction potential.
Logistically, how does that work? So do they basically go every day for an infusion for 5 days in a row?
Yeah.
Or how
So
do you do it?
it's interesting. If you look at protocols across the country, they're highly variable. And the reason is because there's not been a 1,000 patient study to have the definitive answer. So initially, I started doing it every other day for 6 days. And that was more the Johns Hopkins protocol. And what that does from a logistical standpoint is it kind of messes up 2 weeks in your life. So I also found some other folks doing it daily for shorter intervals. And because I'm a researcher, we had a small group, 20 in each side, and we did every other day for 6 days or every day for 4 days. And there was no difference in outcome. They both got equally better. Okay. So I said, rather than screw up 2 weeks, I'll screw up part of 1 week. Because when you do the ketamine, it's 4 days in a row. The only side effect of any note, because it's a very safe and well-tolerated drug, is 10-15% of people get nauseous. 1 or 2% get very nauseous. So we give some people in IV anti-nausea med, and we have backup anti-nausea meds. So it becomes not much of an issue as long as we proactively go after it. Then they're in a reclining chair, blanket on. It's very low lighting. They can either have curated music on headphones or it's very quiet. The infusing nurse is sitting behind them out of their eyesight, but always there. The monitor for the vitals is there as well. And then they get their initial injection. And what mostly happens is you simply pleasantly float away. And then you come back about 60 to 90 minutes later. Occasionally, if someone needs a higher dose, they'll get bolused, and then we'll figure that out and make adjustments for the subsequent ones. People have come out of that saying really neat things. One of our former ketamine nurses actually had a little book that people could write in, and we said, this is life-changing, or, I saw, my sister who, something happened to her years ago, or whatever the story, just story after story about really interesting things. But then what we do in each of those 4 days in a row is we increase the dose, trying to get to what I said earlier. The literature suggests the highest dose group does the best and lasts the longest.
Right.
Right. And we usually get there.
So it's a dose-dependent benefit.
Correct.
Right? So you want to achieve the highest dose that doesn't give side effects.
You got it.
How often do you get hallucinations?
Almost never. So the two big things people ask about are hallucinations. And early on, I didn't know. And the other thing you hear about is this sort of dissociative loss of ego, really scary stuff. I literally can count on one hand the number of patients who have reported that. And I think what that is, as you go up on the dose of ketamine, you will progress from a minimally sedated, that's kind of where the recreational blood levels are. And then as you go up, you get to semi-dissociative. Later, you get full-on dissociative and anesthetic. In that semi-dissociative, they're pretty out of it, but they're still with it enough to try to understand what's going on. And people can get very freaked out at that point.
Interesting.
And they can not see their hand, but realize it may be there, it may not be, and they get a little panicky or whatever. So, I think an inexperienced infuser of this medicine would maybe try to back off or stop the infusion or get all panicky. We simply increase the dose because all you have to do is get them into fully dissociative, and then they're relaxed. And then they don't hallucinate.
Counterintuitive, but yeah, it makes sense. Yeah.
I mean, we also have, we're a center. We're equipped with everything. In addition to a crash cart, we've never used it. We just have everything there. But we also have lorazepam. And if someone really, not the medicine, but just the idea of the procedure, getting them all freaked out, give them a little Ativan first. We try not to change brain chemistry much before we introduce, but sometimes we have to.
What's the longest session duration that you would do for that?
We've done 120 minutes. Normally we do 60 or 60 to 90 minutes.
I wonder if the hallucinations and some of the other side effects are not necessarily dose dependent, but duration of therapy dependent.
Now that we've gotten a whole lot of experience, lots and lots of patients, we're now trying to always tweak it. How can we do better, right? So in addition to dosing and things, we're adding other meds. So for example, another med intravenously that can help headache and some nerve pain would be intravenous lidocaine. So we are piloting doing lidocaine and ketamine together, and sometimes lidocaine by itself. We also are trying IV Depicon, a membrane stabilizing anti-seizure drug, because there have been some anecdotal reports, but again, no great science, that combination really tends to do a little bit better than either alone.
Depakote is great for acute treatment of migraines. I use it in the ED and inpatient setting all the time.
So you could imagine it in with your ketamine.
Combined with the ketamine for sure. So, or the IV lidocaine, which does have evidence.
IV lidocaine, IV magnesium. So, and we really want to try to follow them prospectively and see if we get a sense. Right now, I don't have a great sense, given the limited number of patients that have gotten those things, if they're really night and day changes or not, but we just got to keep going.
I mean, that's essentially like a new generation of migraine cocktail.
Yeah, exactly.
Right? When you have the ketamine involved and other things. Okay. Now, how about acute rescue? If somebody is having a status migrainosis, would you say that ketamine, either in IV form or the nasal form, would that potentially be something that can break it?
Yeah, we have used that. We have at our center what we call a drop-in headache clinic. So for our patients that can't break it, they've got 3-4 days of they come in, and normally they'll get the typical things you would think of. In addition to IV fluids, they get metoclopramide and ketorolac and DHE and all the goodies we're used to. We are sometimes incorporating ketamine in. We had a guy who had a post-traumatic trigeminal neuralgia, and he would have these attacks that were just so paralyzing. And he came in and we gave him stuff and it wasn't getting anywhere. We gave him a big slug of ketamine right then and there, and we got him out of it. So, we've got small numbers now, but we're starting to increasingly use it.
So that's good. Yeah, I mean, for trigeminal, and also I assume for the trigeminal autonomic cephalalgias or the TEC attacks, right? Because those can be difficult and challenging. Same with the clusters, right? The cluster headaches are very difficult to manage.
We have some of those in the database. The numbers are quite good. Interestingly, you want to hear some other odd indications. Severe tinnitus.
Interesting.
So that's a nerve dysfunction. It's an irritable nerve firing.
Debilitating.
Kind of like a neuropathy, right?
It is, in a way.
So we only have a handful of cases. We got her out of it.
Wow.
Yeah, pretty cool.
That's actually very promising.
Yeah.
Because we don't have any good therapies for
No, we
this.
don't. So even something like fibromyalgia, which you don't usually think of as a severe pain, but it can be life-altering.
It can be.
When nothing else has worked, we have tried ketamine. And then the other one that's interesting is just severe irritable bowel syndrome.
Right.
Because that's nerve-related.
It is. Tell me more. So especially with the fibro.
But I would say that's at least 50% of patients.
Okay.
So pretty good to get 3 months or much longer out of it in a tough group to treat.
It is. The common theme between the fibro, the IBS, and some of the other disorders is that they basically have nociplastic pain.
Exactly.
Which is by far the most resistant to therapy, including opioid therapy.
Yeah.
Right? So a lot of those patients don't even benefit from opioids.
Correct.
And so we don't really have any good options. But I'm getting the sense that ketamine potentially might fill that gap. Right? To reset the system and just gonna press that Control-Alt-Delete essentially and restart the whole thing.
I like that.
Right? If patients want to try that at home, so the nasal form, is that something that's available? Is it ever covered by insurance?
Yeah.
What are the safety considerations?
So interestingly, when I started the intravenous ketamine program, it was no coverage at all by insurance.
Okay.
Now, I would say it's at least 65 or more % covered by insurance.
Okay.
And it shocked me.
Yeah, I'm shocked too.
I just said to patients, I think the chance of you getting reimbursed is pretty low, but why not submit it?
Huh.
And now we have the codes for it. And sometimes we're getting some questions back by the insurance and we'll answer them. But
Yeah.
we have patients who are getting it covered.
Wow.
You had asked about the nasal ketamine.
Right.
My experience so far is that is not covered.
Okay.
A. B, it's not very expensive.
Yeah, I would assume.
C, it doesn't do, I believe, and I've seen nothing in the literature suggest that it does the NMDA, AMPA nerve sprouting synaptic connection thing. I think it's working on other mechanisms. So it's not a substitute for the IV,
Right.
but it can help a little afterward.
So the discouraging thing about ketamine that I think, I have at the back of my mind and a lot of other people and patients might have at the back of their minds is that the studies were really small. We didn't have any robust studies, right, with big sample sizes.
Yeah.
And so people have kind of discounted it.
Yeah, I mean,
Right.
there's a lot of bad science out there.
Yeah.
And again, as a researcher, we have our statisticians design our big trials to know how many patients you have to put in to get an answer. And I would suggest to you that if you've got 12 patients in a study, if the ketamine does better, great. But if it doesn't, it's not what we call powered to tell the difference. Right. So it's really difficult. Big research is done with big dollars.
Right.
And since there's not money in something that's from the 1960s,
Yeah, fair enough.
If you tweaked the chemical and you made it a proprietary product, you could then do something like that.
Which is interesting, right? Because, ketamine is not new, right? So, when was it FDA approved for?
1961.
That's for anesthetic use.
For anesthetic use.
Right. And when was it initially used for chronic pain of some sort?
Yeah, although it's not actually technically approved for
It's
that.
not.
It's been about 12, 14 years. It's not been that
Yeah,
long.
right? Yeah, maybe 15 years
Yeah.
or 20 years off-label. And then in terms of long-term complications and side effects, how much data do we have in terms of risk for liver, bladder, things of that sort?
Yeah. So longitudinally in an individual, we have very limited data. But what we have is millions of patients who have gotten it acutely in ICUs and ORs and things like that. So we have a database that's 40 years old, 50 years old. And looking at it and looking at the federal adverse reporting system, which I have, there's no signal that jumps out.
Okay.
But we haven't, most of those patients were acute use, several day use. It'd be interesting to study, a patient doing it for 2 years straight and see what happens. We don't have that data.
Okay. But so far nothing is popping up
Nothing
as a
at all.
huge possible risk.
Yeah.
Okay. Okay, so as a last question, if you had to pick just one type of patient or condition that would be the most appropriate or promising when it comes to ketamine?
So I think complex regional pain syndrome, it is just so functionally limiting. It's so difficult to treat. It's essentially sensitized process. It's kind of custom made for ketamine.
Yeah, CRPS is definitely one of the most disabling chronic pains out there.
Yeah.
And at least 20% of those patients end up with refractory pain after 8 years, despite maximal therapy, right?
Yeah.
So I think that would be a really good option for those who, some of them become suicidal.
Yep. Absolutely.
I think along with trigeminal neuralgia, both are seem to be known in the community as the suicide diseases.
Exactly.
Right?
Throw in cluster headache.
Cluster headache to some extent, yeah. I feel like, a lot of people jump in to kind of nominate their disorder, but yeah, between CRPS, trigeminal, and cluster,
Yeah.
I would say probably the top three.
Mm-hmm.
So it's good to know that there's at least an option on the horizon. So
Right.
yeah, that was very helpful.
Yeah.
Thank you for all the information on it.
Pleasure chatting with you, Alex.
Yeah, and then so just for people to know, this kind of therapy is offered in Stamford, in Connecticut, and in Westport,
Correct.
I believe, right? Yeah.
Yep.
Awesome, great.
All right.
That's it.
Thank you.